Now, the second part of the inflammation of the nose and the paranasal sinuses. Inflammatory disorders of the paranasal sinus, which is sinusitis. Sinusitis is the inflammation of the mucoperiosteal lining of one or more of the paranasal sinuses. It's either acute sinusitis, chronic sinusitis, or fungal sinusitis. The definition of acute sinusitis is the acute inflammation of the mucoperiosteal lining of one or more of the paranasal sinuses. It can be caused by Streptococcus pneumoniae, Haemophilus influenza, Moraxella catarrhalis, or anaerobic organisms causing maxillary sinusitis of dental origin. Roots and sources of infection. Where can infection come, or how can infection come to the nasal sinuses? It can come through the nasal root. The infection reaches the sinuses via its ostium, coming from acute rhinitis, which is commonest, or swimming and diving in polluted water, or nasal packing, or nasal foreign body. It can come from the teeth at the dental root, causing maxillary sinusitis, especially infection of the second premolar or first molar teeth, or infection from oroantral fistula, which happened after tooth extraction. Infection can come externally too. It can come through a compound fracture of the sinus or a penetrating foreign body as gunshots. The patient complains of fever, headache, anorexia, and malaise, and locally he complains of nasal obstruction, nasal discharge, hyposmia, or anosmia due to the nasal obstruction. And in dental maxillary sinusitis, it causes cachosmia, which is smelling of bad smell, and facial pain. It's severe and increases by straining and leaning forwards. It's due to accumulation of discharge in the sinus under tension, which is called tension pain. Inflammation of the ethmoids or ethmoidal sinusitis, the pain will be between the eyes. Inflammation of the maxillary sinuses will be over the cheek. The frontal sinuses will be over the forehead, and it is characteristically periodic. It starts in the morning, decreases at noon, and subsides in the afternoon. Sphenoid sinusitis causes pain behind the eye. By examination, we will see the fever, which is higher in children, and by external examination, we will feel tenderness over the affected sinuses. The ethmoidal sinuses, tenderness over the medial canthus, the maxillary sinusitis over the cheek, and the frontal sinusitis over the floor of the sinus at the roof of the orbit. By anterior anoscopy, swelling and hyperemia of the nasal mucosa is seen in the middle meatus or the superior meatus. A mucopurulent or purulent discharge can be seen in the middle meatus if the infection is in the anterior ethmoids, maxillary or frontal, or in the superior meatus if the infection is coming from the posterior ethmoids, and in the sphenoethmoidal recess if the infection is into the sphenoid sinuses. What are the investigations for a case of acute sinusitis? Radiologically, which is not necessary because diagnosis is usually evident by clinical examination. But if we do a plain X-ray, we will see an opacity or air fluid level. Watch the arrows on the figure. Treatment. Medically, we give general measures as antibiotic for 10 to 14 days, decongestant, supportive, and symptomatic measures that rest ample fluids analgesics and antipyretics. Locally, we can give nasal decongestants and steam inhalation. When we do surgical treatment, when medical treatment fails or when complications threaten or occur, and it's better avoided because it may lead to osteitis or osteomyelitis of the sinus wall. And how is it done? It's done by endoscopic widening of the natural ostium of the affecting sinus to restore the normal ventilation and drainage of the affected sinuses through its natural ostium. So, maxillary sinusitis will be done by endoscopic middle meatal antrostomy, frontal sinusitis by endoscopic frontal sinusotomy, sphenoidal sinusitis will be done by endoscopic sphenoidotomy, and ethmoidal sinusitis will be done by endoscopic ethmoidectomy. Chronic sinusitis. It's chronic inflammation of the mucoperiosteal lining of one or more of the paranasal sinuses. Etiology. It is due to prolonged obstruction of the natural ostium of the paranasal sinuses. Prolonged ostium obstructions will cause inadequate ventilation and drainage of the sinus, leading to overgrowth of organisms. Infection. Infection will cause inflammation of the mucous membrane, edema, and damage of the cilia, and more to defective ventilation and drainage of the sinus. Chronic infection. It's the chronic infection. How this happened? This happens by prolonged ostium obstruction by anatomical conditions as deviated nasal septum or enlarged middle turbinate, or pathological conditions as nasal allergy or nasal polypi. Also, incomplete resolution of acute sinusitis due to inadequate treatment or resistant organisms or low patient resistance can lead to chronic sinusitis. Organisms are usually mixed aerobic and anaerobic organisms, and the patient complains the same complaint as acute sinusitis, but with no general symptoms, and the local symptoms are dull. The pain is dull due to absorption of air from the sinus as a result of obstruction of the ostium, called vacuum pain. Remember, in acute sinusitis it was tension pain. And by examination, anterior rhinoscopy can show the mucopurulent or purulent discharge similar to acute sinusitis. Investigation is required. Nowadays we don't do plain X-ray, but CT scan should be done because it shows the opacity or thickening of the mucosal lining of the affected sinus, which leads to proper assessment of the extent of the disease and will show the cause of ostium obstruction and exclude complications. Culture and sensitivity of the discharge can be done for giving antibiotics. How to treat chronic sinusitis? Chronic sinusitis can be treated medically by antibiotics and better according to culture and sensitivity, mucolytics, local nasal decongestants, and alkaline nasal wash. And surgically, when medical treatment fails due to frequent attacks or persistent disease, or when complications threaten or occur. And how is it done? It is done by functional endoscopic sinus surgery to restore the normal ventilation and drainage of the affected sinus through its natural ostium, allowing the sinus mucosa to return to its normal functioning state. And how that is done? How this functional endoscopic sinus surgery is done? Well, first we remove any cause of nasal obstruction as polypi or enlarged middle terminate, and then endoscopic widening of the natural ostium, the same as we done in acute sinusitis. Fungal sinusitis. Fungal infection of the mucoperiosteum lining of one or more of the paranasal sinuses. It can be non-invasive fungal sinusitis as the fungal bowl and allergic fungal sinusitis, or invasive fungal sinusitis, which is classified to acute fulminating fungal sinusitis and chronic indolent fungal sinusitis. Fungal bowl. In fungal bowl, the patient's immunity is immunocompetent, means a normal person. The causative organism is Aspergillus species, and the pathology of this disease is due to accumulation of fungal hyphae within the paranasal sinuses, usually the maxillary or the sphenoid, with minimal mucosal reaction. The clinical picture is unilateral nasal discharge, and the CT scan is diagnostic with unilateral sinus opacity. Treatment is endoscopic removal of the fungus bowl. For allergic fungal sinusitis, the patient's immunity is atopic, which means he has multiple allergies. The causative organism is Aspergillus species, and the pathology is fungal infection producing an allergic reaction in the sinus mucosa, formation of polypi, and production of a special type of mucin called allergic mucin. The patient complains of unilateral or bilateral nasal obstruction and brownish tenacious offensive discharge. By examination, you can see the unilateral or bilateral multiple nasal polypi. CT scan is also diagnostic. A unilateral or bilateral sinus opacity can be seen with characteristic focal hyperdense spots. Watch the CT scan on the right side. The treatment of allergic fungal sinusitis is endoscopic removal of the polypi, the fungal debris with proper ventilation and drainage of the sinus, followed by systemic and local steroids. It's an allergic condition, remember that. In acute fulminating fungal sinusitis, the patient's immunity is immunocompromised as chemotherapy aids or uncontrolled diabetes. The causative organism is usually Mucor species and called Mucormycosis. The pathology of the acute fulminating sinusitis is due to intravascular thrombosis and gangrene. The patient will show signs and symptoms similar to acute bacterial sinusitis with rapid deterioration of general condition. The nasal mucosa is covered with blackish crusts, gangrene, and the complication is due to extension to the palate orbit and intracranial cavity, and it is rapidly fatal disease. CT scan will show unilateral opacity involving most of the sinuses extending beyond the sinuses. Treatment is controlling the predisposing factor and giving antifungal medical treatment as amphotericin B, and remember it's nephro and hepatotoxic. Surgical debridement of the necrotic tissue. In chronic indolent fungal sinusitis, also the patient is immunocompetent, not immunocompromised, and the causative organism is Aspergillus. And the pathology is similar to acute fulminating fungal sinusitis, but the picture has insidious onset and slowly progressive. Complications are similar to acute fulminating fungal sinusitis but are late. CT scan and treatment are similar to acute fulminating fungal sinusitis. Now we move to another part of the nasal part of our syllabus, the reactive disorders of the nasal cavity. Definition: it is abnormal reaction of the nasal mucosa to a specific allergic factor or a non-specific non-allergic factor. They are either allergic rhinitis or vasomotor rhinitis. Allergic rhinitis is the abnormal immune reaction of the nasal mucosa to a specific allergic factor, allergen. and it is common. It's about in 10 to 20% of the population, and the types of allergic rhinitis are either seasonal or perennial. Season means occurs in seasons, for example hay fever, which occurs in spring, and the perennial is persistent all over the year. The responsible allergens are foreign factors which are harmless to normal individuals, like inhalants, which are the commonest, and it may be seasonal as pollens, grasses, and molds, or perennial as house dust, dust mite, animal dander, and feather. Ingestants can be like egg, milk, wheat. Injectants like penicillin, or contactant like face powders. The predisposing factor, the condition is usually inherited as a simple recessive trait of allergic rhinitis. With initial exposure to the allergen, plasma cells get stimulated to produce immunoglobulin E. Immunoglobulin E will get attached to the mast cells to be sensitized mast cells. With further exposure to the allergen will get attached to the IgE on the mast cells, which will be stimulated and cause degranulation of the mast cells and producing the allergic mediators. What are the symptoms of allergic rhinitis? Well, nasal itching, repeated paroxysmal sneezing, bilateral profuse watery nasal discharge, vasoactive nasal obstruction alternating from side to side, and by examination the nasal mucosa, especially the turbinates, is swollen, moist, and pale bluish, and the nasal cavity is full of watery discharge. Commonly associated allergic manifestations can be found, like conjunctival and bronchial allergies. What are the sequelae? Well, sequelae of allergic rhinitis can lead to recurrent acute rhinitis and chronic hypertrophic rhinitis, recurrent acute and chronic sinusitis, and ethmoidal polypi. What to do as an investigation for a patient of allergic rhinitis? To confirm the diagnosis, microscopic examination of the nasal smear will show excess eosinophils, and by blood examination you will see eosinophilia, increased total plasma IgE levels. To define the offending allergen, we can do nasal provocation tests, skin sensitivity tests, or RAST, which is radio allergosorbent tests, to detect plasma IgE to a specific allergen. And we can do CT scan to detect complications. This is a figure of skin sensitivity test. How to treat allergic rhinitis? Medically by antihistaminics, steroids, short course in severe cases, or local treatments like steroid sprays, safe and effective, surgical treatment for treatment of the complications of the allergy, not the allergy itself. We can do reduction of the inferior turbinate when complicated by hypertrophic rhinitis, or ethmoidectomy when complicated by sinusitis or ethmoidal polypi. Remember, medical treatment should be continued after surgery to avoid recurrence. Vasomotor rhinitis. It is abnormal autonomic reaction of the nasal mucosa to a non-specific non-allergic factor. Its mechanism is unknown. Probably the responsible factor causes overactivity of the nasal parasympathetic system, causing vasodilation of the blood vessels, leading to congestion, increasing the capillary permeability, leading to edema, and increased secretion of the seromucinous glands, causing rhinorrhea. The etiology may be environmental factors as irritants, as dust and tobacco, and change in the humidity or temperature. Endocrinal factors as pregnancy, menopause, puberty, old age, and contraceptive pills. Drugs like antihypertensive and the abuse of vasoconstrictive nasal drops, which is called rhinitis medicamentosa. The clinical picture is similar to allergic rhinitis but without itching, and associated allergic manifestations is not found. The investigation is similar to allergic rhinitis but are negative. The sequelae similar to allergic rhinitis but with no ethmoidal polypi, and the treatment is similar to allergic rhinitis but with no antihistaminics. And prophylaxis is done by avoidance to exposure to the responsible factors. Thank you.